So starting our class, this is a microscopic anatomy of the liver. This is a hepatic lobule, which is a functional unit of the liver. And the periphery of the hepatic lobule, there are portal triad, the bile duct, portal vein, and the hepatic artery. And the center lies the branch of the hepatic veins, that is interlobular vein. In between these portal tracts and the central vein, there is hepatic parenchyma with the plates of hepatocytes and the interspersed sinusoids in between, which carries the blood from the portal tract to central vein. Coming to the portal tract is formed by the three structures, which is bile duct, portal vein, and the hepatic artery. So most of the blood to the liver is carried by the portal vein and followed by the hepatic artery. The blood of the hepatic artery is mostly majorly oxygenated, and the portal vein carries the partially deoxygenated blood. So this is the inflow of the liver, and this is the outflow. The blood is there is hepatofetal flow to the liver, and the portal vein carries the blood via sinusoids to the central veins. So this is the flow of the blood. So this part, which is the periportal area, is the most oxygenated part because of the oxygenated blood adjacent to this. And this part, the central vein, which is the pericentral area, is the most susceptible for ischemia because of the decreased oxygenation through these zones. So this will be periportal zone, this will be pericentral zone, and this is the intermediate zone. This is the flow of bile. The bile is produced by the hepatocytes, and through the canalicular circulation, it goes to the bile ducts. So this is the hepatophagal flow of the bile. Coming to the hepatic zonation, as already told, the periportal area is zone 1, zone 3 is pericentral area, and the zone 2 is in between. So these zones have distinct functions also because of the high oxygenation in the periportal zone and those processes which require high oxygen requirement, the oxidative metabolism, gluconeogenesis, and the ureagenesis occur predominantly in the zone 1, and in zone 3 where there is relatively less oxygen, the glycolysis, liponeogenesis, and the xenobiotic metabolism is there, and the transitional zone performs both the functions. So as we see, these zones are distinct but not well defined because the transitional zone is still there. The different pathologies of the liver involve different zones, and this is based on the functions of these zones. We will see later. So why this is important to understand this lobular anatomy, because the different etiologies affect different zones, and histopathology is diagnostic in these situations. We can see the alcoholic liver disease predominantly involve the pericentral area. As we already seen, the xenobiotic function is the function of the zone 3 predominantly. So ALD involves zone 3 predominantly. The NASH, non-alcoholic steatohepatitis, involves pericentral zone, and chronic viral hepatitis involves periportal and interface areas predominantly. Also, the autoimmune hepatitis also involves the periportal and interface areas. So the burden of virus is predominantly in the periportal areas and interface areas because of the rich blood supply to those areas. And also the immune-mediated injury is also predominant in the periportal and interface areas because of the immune-mediated injury in the abundant blood supply. So that's why we need to exclude significant alcohol intake before we diagnose non-alcoholic fatty liver disease. And also we need to exclude viral hepatitis before we diagnose autoimmune hepatitis because of the similar liver injuries in these conditions. Coming to the hepatic portal system, the portal system collects venous blood from the lower esophagus, stomach, duodenum, intestine, and spleen. The normal hepatic circulation is high flow and the low resistance system. Normally there is least resistance, and the blood coming from the GI tract goes to the liver, and from that it goes to the venous circulation of the systemic circulation. The portal system delivers around 1 to 1.5 liters of blood per minute into the sinusoids with the normal venous pressure of 5 to 10 mmHg, and this is around 20% of the whole cardiac output. The portal pressures, if more than 10 mmHg, indicate the portal hypertension. Portal pressure is the product of intrahepatic vascular resistance and portal blood flow across the hepatic vasculature. When the portal pressure increases above the threshold of 8, collaterals begin to develop between the portal vein and the tributaries. So this is the portal circulation. This is the systemic circulation. This is the portal circulation. The systemic circulation from the inferior vena cava and its branches, the portal vein, the left branch, the right branch, and this is the splenic vein, the superior mesenteric vein, the inferior mesenteric vein, and this area is the splenic circulation. The splenic circulation is concerned with the venous drainage to the intestine and the adjacent pancreas and the spleen. So this is basically in cirrhosis. What happens is there is decreased flow to the liver because of the intrahepatic resistance, and there is the hepatovital flow is reversed. It becomes the hepatofugal. So there is pooling of blood in this circulation, the splenic circulation. So when we treat portal hypertension, the mechanism is to decrease this pooling of the blood in the splenic circulation and to vasoconstrict this splenic circulation so that there is increased blood flow to the liver along with the venous return to the heart. So when if you have seen the patients of cirrhosis, we see that there is altered hemodynamics in those patients. In those patients, since there is increased portal flow resistance, there is decreased end-diastolic volume, and there is decreased blood pressure in patients with cirrhosis, secondary to the decreased venous return. So there is decreased blood flow, and there is a reversal of the blood flow in the splenic circulation. Coming to the varices, the most common varices in the portal, these cirrhotic patients are the esophageal varices. So I have not depicted those varices. These are all the ectopic varices which are formed in the stomach and the lower esophagus. The cardiac varices are formed because of the collateral dilatation on the left gastric vein, and the short gastric vein and the posterior gastric vein predominantly form the fundal varices. The gastroepiploic veins form the isolated gastric varices. Coming to the concept of fibrosis. Fibrosis is basically the response to the liver injury, and it is the healing of the liver parenchyma secondary to the scarring. This is the staging of the liver fibrosis. The F1 stage. The F1 stage is just the expansion of the portal tract secondary to the inflammation and the injury. And in the second stage, there is the portal tracts are connected with the septa, and there is the portal to portal fibrosis. So this is F2. F3 is multiple septa formation between the portal to portal tract and along with the formation of septa between the portal to central. So portal to central along with the portal to portal fibrosis is F3 fibrosis. And whenever there is formation of the nodules along with the extensive fibrosis and the portal to portal and portal to central fibrosis, the bridging fibrosis, this is F4 fibrosis, and it is metavir stage 4 cirrhosis. So this is how the liver fibrosis progresses. F0 is without fibrosis, F1 initial, F2 intermediate, and F3 is advanced fibrosis, F4 is cirrhosis. So when we diagnose cirrhosis, it is extensive fibrosis along with nodular regeneration and the distortion of liver architecture. So in the cirrhosis patients, there are two effects: the impairment of the liver function and impairment of blood circulation through the liver. So the obstruction of blood flow through the hepatic lobules leads to the increased pressure in the portal vein, portal hypertension, increased pressure in the portal vein, and the manifestation of the collaterals, as we already seen the varices, along with the exudation of fluid in the abdomen, ascites, and the congestion of venous system, splenomegaly, and pancytopenia. So this is the basic I wanted to tell. This is, I think it will be easier to proceed with. Thank you.